Hello everyone. So today we will start our second video on rhythm disorders. Today we will mainly discuss about ventricular rhythms. In the previous video we discussed about supraventricular rhythms such as junction rhythm, atrial rhythm and normal sinus rhythm and sinus arrhythmia. So today we will discuss about ventricular rhythms. So looking at our first ECG, you can see that this complex is abnormal. What's abnormal in this complex? We can see that this complex is broad. This complex is broad around 5 small squares. Generally, Cure's complex is 2.5 small squares, but it is 5 small squares, so it is broad complex. It is not preceded by any P wave. There is absence of P wave. So this complex seems to be originated from ventricle, either right or left ventricle. So this is a ventricular complex. Now, if as we can see that if this is normal sinus beat, this is normal sinus beat, then according to the pacing of the SA node, next beat should come at this level. But the beat is coming prematurely. Then the normal sinus node, normal SA node firing, this beat is coming at this point of time. So this is premature complex originating from ventricle. So it is premature ventricular complex. PVC, or we can say VPCs, ventricular premature complexes. This is a bizarre shape complex. You can easily identify these type of complexes on ECGs. Now, one more thing. According to the SA node firing, SA node firing, the normal sinus complex should be यहाँ पे. And the normal SA nodal beat should come here, and the next nodal SA nodal beat should come here, and the next SA nodal complex is coming here only. So it means after this complex, it took a compensatory pause. It did not set the firing of the SA node, pacing of the SA node to a new level. The SA node is continuing firing to its own pace. At the scheduled timing, the next SA node impulse is coming. So this is compensatory pause. So VPCs or PVCs always follow a compensatory pause. Coming to the next ECG. Now identify this beat. Is this a VPC? Wrong answer. This is not VPC because this is not coming prematurely. Yes, it is ventricular beat. How we can say that is ventricular beat? It is a broad complex QRS. Okay, there is no P wave preceding it, so it is ventricular origin, ventricular complex. But this is not coming prematurely because according to the SA node, it should, as normal beat should come here and premature beat should come here. So this is not premature beat. SA node did not fire, atrial did not fire. There is no junctional pacemaker is firing. So ultimately, ventricular focus take over it. Ventricular focus take over, and it became a ventricular beat. Ventricular focus generated an impulse, and the whole of the ventricle depolarized and produced a ventricular beat. So this is known as ventricular escape beat or escape ventricular complex. It follows a non-compensatory pause. How? Next impulse, if SA nodal impulse should come, it should come here. Sorry, it should come here, but impulse is not coming here. It is coming prematurely. This P wave come a little, थोड़ा पहले आ गई ये P wave में, और इसकी वजह से ये पूरा कॉम्प्लेक्स थोड़ा सा पहले आ गया. So this is following a non-compensatory pause because it is not premature ventricular complex. If such type of escape rhythms come regularly like this, at a rate more than 100 beats per minute, 3 or more than 3 consecutive beats, it is known as ventricular tachycardia, VT. Coming to the next ECG. सो ये रिदम क्या है? वही बिजारे कॉम्प्लेक्सेस है, ब्रॉड क्यूरस कॉम्प्लेक्स है, ये एस्केप क्यूआरएस कॉम्प्लेक्स या फिर वीपीसी से। अपन ये नहीं कह सकते ये एस्केप रिदम है या फिर वेंट्रिकुलर प्रीमेच्योर कॉम्प्लेक्स है, क्योंकि अपने पास कोई और कॉम्प्लेक्स नहीं है जिससे अपन कंपेयर कर सके कि ये प्रीमेच्योर बीट थी या फिर एस्केप बीट थी। बट as we can see that these escape rhythms or premature VPCs are coming regularly at a rate. इनकी रेट क्या है? दिस इज ब्रेडिकार्डिया, वन वन बिग बॉक्स, टू बिग बॉक्स, थ्री बिग बॉक्स और more than three big boxes or more than six big boxes of big squares, not big boxes, big squares of our normal ECG paper. So it will come around 40 or 38 beats per minute. So this is bradycardia. This is not sinus bradycardia. This is ventricular rhythm. So ventricular, these type of VPCs coming at 38 or 40 beats per minute, less than 60 beats per minute, regularly, without any sinus rhythm or P waves. This is known as idioventricular rhythm. Idioventricular rhythm. ये रिदम अपन को कहाँ देखने को मिलती है? दिस रिदम इज सीन आफ्टर perfusion, the myocardial ischemia, after thrombolysis, cardiomyopathy. Next ECG. Now look at this ECG. What we can interpret or what we can see from this ECG. First of all, this is a regular, equally spaced. Next, this is broad QRS complex. See, one small box, two small box, three small box, three and half small box. Normal QRS is two and half small boxes. So this is three and half small boxes. So this is broad QRS complexes. Broad QRS complex. Next, what we can see, there are no P waves. No P waves. Now broad QRS complexes, no P waves. You can see this is ventricular rhythm. Rate, looking at the rate, around 11 small squares. 11 small squares. So calculating rate 1500 divided by 11, around 136 beats per minute. So broad QRS complexes coming at 136 per minute beats per minute. This is most probably ventricular tachycardia. Now, how do we confirm that this is ventricular tachycardia or not supraventricular tachycardia with aberrancy? So let's understand the concept of SVT with aberrancy and VT. Broad QRSs. Okay, so this is V1, this is V6. If we say that V1 has this type of QRS complex, this is P wave, this is QRS, and this is our T wave, and this V6 lead has this type of QRS complex. So this is what RBB morphology, right bundle branch morphology of the broad QRS complex, right bundle branch. And if the V1 shows this pattern, broad QRS complex, and this is broad QRS complex, negative in the V1 and positive in the V6. This is left bundle branch morphology. So these are also broad complex QRSs. Now, if this patient develops tachycardia, so it will It will also have broad chorus complexes with tachycardia. Now, how will we identify that this is broad chorus complex tachycardia as LVB with the tachycardia or ventricular tachycardia? So, if this patient who is having bundle branch block with tachycardia, so he will have bundle branch block with tachycardia like this. Let's suppose we don't draw T waves. So this is like P wave, then this is sorry, this is P wave, and this is broad complex, then another P wave, then another broad complex, then P wave, then broad complex. So every broad complex is preceded by a P wave at regular intervals. This shows that there is atrial rhythm, SM sinus rhythm, which is going into ventricle, which is stimulating ventricle. So every ventricular complex is followed by E wave at a regular interval. But this does not happen in the VT. What VT has atria pacing at its own rhythm and ventricle beating at its own rhythm. So there is a AV dissociation. P waves occur, sinus rhythm occur, but sinus P waves occur, but at hidden in the broad complexes. Like these arrows are marked where there is a P wave P वेव जो उसके वेंट्रिकल अपने वेंट्रिकुलर क्यूआरएस कॉम्प्लेक्स के ऊपर सुपर इम्बेडेड है, लाइक यहाँ पे यहाँ पे है, यहाँ पे है, ये यहाँ पे है. तो ये रेगुलरली नहीं आ रही, ये कहीं पे भी एम्बेडेड है. इसका मतलब ईवी डिसोसिएशन हो रहा है. साइनस अपने रेट पे फायर कर रहा है और पीवी डेवलप कर रहा है, और वेंट्रिकुलर अपने रेट पे कर रहा है. जहाँ पे वेंट्रिकुलर वाली अपन को ज्यादा दिख रही है पीवी से, सॉरी, इसका मतलब है कि वेंट्रिकुलर टेकिकार्डिया है, वेंट्रिकुलर पेस ज्यादा कर रहा है. और दूसरे इंडिकेटर्स क्या होते हैं वीटी के? अब जो अपन ये रिदम देख रहे हैं, इसमें ये दो अबनॉर्मल बीट्स दिख रही हैं अपने को. अबनॉर्मल मतलब जो इन बीट से अलग है. तो ये बीट कैसे फॉर्म हो रही है? ये अपन को दिख रहा है कि ये कोई ब्रॉड कॉम्प्लेक्स टेकिकार्डिया है जिसमें ईवी डिसोसिएशन दिख रहा है अपने को. उसके बाद अपन ने देखा कि ये एक अलग सी बीट दिख रही है अपने को. दिस इज फ्यूजन बीट. मीन्स यहाँ पे वेंट्रिकल और एसे नोड दोनों ने फायर किया है, वेंट्रिकल दोनों से स्टिमुलेट हुआ है. So this is a hybrid complex formed by the stimulation of the ventricle by both SA node and the SA node and the ventricular pacer. And this complex appears to be normal. Normal, that is जो SA nodal complex होता है, P wave, QRS, P wave. Normal width of the QRS, narrow QRS. So this is capture beat. Actually, what happens during even the ventricular tachycardia, sometimes the SNodal impulse captures the ventricle in that time in which it is not refractory and it can be stimulated by the SNode. The SNode is regularly generating impulses, but it cannot reach the ventricle because ventricle is already stimulated by the ventricular focus, which is firing at a very fast rate. But in the between of this, sometimes SNodal impulse reach the ventricle when it is not refractory and it generates the normal ventricular complex, stimulates the ventricle. So this capture beat, if we can find the capture beat or fusion beat or both in a broad complex tachycardia, it is highly suggestive that this broad complex tachycardia is ventricular tachycardia, not supraventricular tachycardia with aberrancy or any bundle branch block with bundle branch block tachycardia. It is ventricular tachycardia. These fusion beats, these capture beats and fusion beats are occurring in the ECG. This type of question you can get in MCQ. They will show this type of ECG with not this wave, either this or this wave, and ask this is capture beat or this is capture beat or this is fusion beat. The fusion beat is fusion, hybrid of the both impulses. So it will be bizarre or it will be hybrid. But capture beat is when the SA node captures the ventricle during the ventricular tachycardia and produces a normal stimulation of the ventricle, narrow complex. What are the other indicators of ventricular tachycardia? In the ventricular tachycardia, the interval from the R wave to the bottom of the S wave, interval from the R wave to the bottom of the S wave is more than 0.10 seconds. This is starting of the R wave. In the ventricular tachycardia, these type of complexes are formed. and this is the S wave, nadir of the S wave, so bottom of the S wave. So this distance is more than 0.10 seconds, or more than 2.5 small squares. So if the Brugada sign is positive, the Brugada sign is there, it means that broad complex tachycardia or broad complex tachycardia ECG is having is VT. Now next is Josephson sign. Josephson sign is notching. Josephson sign, SON, small notching near the low point of the S wave. If this is S wave and if this S wave has notching near the lower point, this is Josephson sign. It is also suggestive of ventricular tachycardia. So now look at this ECG. There are also broad complexes. There is also tachycardia. We can see that these two waves have 5 small squares in between, 5 or 6 small squares. So it will be around 280 beats per minute or 300 beats per minute. So this is definitely tachycardia. These are broad complexes. But the axes of these complexes are changing regularly. Like this, this, this undulating sinusoidal appearances. Actually, this VT, this is also ventricular tachycardia because the broad complex tachycardia, and but this is prolonged QT interval. So this looks like this. It is known as Torsade points. Rate 200 to 250, underlying prolonged QT interval, undulating sinusoidal appearances, and changing of the QRS complex axis जो है वो regularly change होती है इसकी. Now identify this ECG. This is broad complex tachycardia, okay, but you can't identify this as a QRS, any T wave. Nothing can be identified, but we can identify that only there are some broad complexes regularly occurring. So no identification of QRS, T wave, ST segment, and the rate is more than or equal to 300 beats per minute. So this is ventricular flutter. Now the next ECG. We can't identify anything in this ECG. No QRS, no T wave, nothing but we can only say that some chaotic activity or some stimulation activity is occurring in the monitor or ECG. Multiple chaotic activity, because there are multiple ventricular pacemakers that are having their own firing at. So this is suggestive of ventricular fibrillation. Now coming to this ECG. So after reading all of this, let's try to identify the rhythm of this ECG. So on a look, it seems to be tachycardia. Without calculating even heart rate, we can say that this is tachycardia, definitely. See, around 1 and 6 small boxes, or equivalent to 300 or 280 beats per minute. Is this regular? This is regular. Narrow or broad complexes? Broad complex. Clearly we can see in the V1 where complexes are actually forming. One, two, and three. 3 small boxes. So this is broad complex tachycardia. Now this is SVT or ventricular tachycardia. So one rule is this: always consider VT. If there are no signs, if you can't prove it SVT, it is always VT. Treat it as VT. This is for practical purposes, but for MCQ examination, you have to clearly see it is SVT or VT, because they will provide ECG in which you can really differentiate. In practical, such ECGs don't exist. Sometimes you have to consider VT If you don't find any sign on the ECG, to consider it as SVT with evidency. So first point that this is a broad complex tachycardia, then this is occurring regularly. Now you have to see for AV dissociation. This is P wave, here no P wave, this is P wave, this is P wave, this is P. So there are P waves occurring hidden in the QRS complexes just after the QRS complex. Sometimes just after, sometimes one to two small squares after this, or sometimes no P wave. So this is AV dissociation again. So we can say definitely that this is ventricular tachycardia, monomorphic ventricular tachycardia, because all are of same morphologies. Completing this session of ventricular rhythms here, and now finally this one question. After thrombolysis of a patient of acute ST elevation MI, ECG shows the following rhythm. Okay, patient is having blood pressure of 162 mm of mercury and patient maintaining oxygen saturation of 98%. As a ICU resident, what will be your next step? So please look at this ECG and comment the answer below.